So, hi everyone, good afternoon. We now get to the last seminar, virtual seminar of the year, and I have the pleasure to introduce you Dr. Heinz Laubli from the University Hospital Basel in Switzerland. Dr. Laubli obtained his MD and PhD at the Institute of Physiology at the University of Zurich. After which he became a specialist. Can you hear? It's like, okay. My YouTube was turned on. After which he became a specialist in general internal medicine and medical oncology. He then moved to the US and developed his postdoctoral studies at the Department of Cellular and Molecular Medicine at the University of California, San Diego, where he was a lab mate of Professor Federico Alisson, who is here and was the one to suggest his name. Dr. Laubli is now the group leader of the Cancer Immunology Laboratory at University Hospital Basel, where he works on cancer immunotherapy with a focus on the role of glycans and glycan-binding receptors in anti-cancer immunity. So I'd like to thank Dr. Heinz Laubli for accepting our invitation to be here and for sharing his data with us. And I think it will be very fruitful for us to watch his talk. Okay?
Thanks a lot for the nice introduction. And I mean, if you want to ask something during the talk, I think it's fine to do it. I don't see you at the moment. Maybe you see me. I hope you see me. Or maybe
yeah, you won't be able to see us during the talk.
No, that's fine. Don't worry. That's
okay.
fine. Okay. So if something is, no one understands anything or someone is angry with me, you should just interrupt me because I cannot see you as I wanted to say. Okay.
Okay, no, it should be fine.
So thanks a lot for the introduction and for the invitation. And I'm very glad to talk about the interaction between Siglec receptors that bind to sialic acid containing glycans as a potential to improve and as a potential to improve this cancer immunotherapy by targeting this interaction actually. And we believe that this interaction between sialoglycans and Siglecs could become a new immune checkpoint as it is known for PD-1 or CTLA-4. Obviously, it's not so far yet that we can be sure that this translates into clinical applications, but we have quite some preclinical data for that. So I would like to introduce you to this pathway during the next minutes, and I hope you will learn something. So you already mentioned my stay at UCSD, and we had indeed an overlapping time at UCSD between 2013 and 14. Fred and I, as you can see him in the middle of this picture, and you can see us here in the cell culture lab and Archie Dworki's lab, where it was quite crowded actually, and you don't have mouth protections here, so it's not. I'm not used to see people anymore that don't wear any masks at the moment, but that's how it looked a few years ago, also in California. Okay, so I'm very glad to start with these pictures, but then I want to be a bit more serious, and I would like to show you that cancer immunotherapy has really improved, as you probably know, of our patients that we treat. So as you can see, targeting of CTLA-4 inhibitory receptor or PD-1 inhibitory receptor or its ligand PD-L1 on the opposite side on APCs or target cells, cancer cells, can actually reactivate the T cell quite well. And what we can see here, even in advanced melanoma, when patients about 10 to 15 years ago would have died within 8 to 9 months, if you treat them with anti-PD-1 and anti-CTLA-4 blocking antibodies, you can see that more than 50% of the patients are still alive after 5 years, 60 months. This is quite amazing because this has really improved the outcome of those patients. It's clear that the other 50% are still dying, and we certainly have to find new treatment approaches. If you look, for example, in lung cancer, then with PD-1 blocking antibodies, this is second-line non-small cell lung cancer. And as you can see here, the 5-year survival, although it's still better than using chemotherapy, docetaxel here, the red curve, you can see that after 5 years, only a bit more than 13%, this is certainly an improvement, but only 13% of the patients are still alive. And there's a big gap. And I think what you can see from those two graphs I've shown you now is that with cancer immunotherapy, we really can improve the survival of patients. And what you can also see is that a part of the patients undergo or will go into long-term remissions, that we really believe that some of the patients, even at advanced disease stage, we still can cure them actually with those therapies. So immunotherapy really works. This has also led to the Nobel Prize for Jim Allison and Tasuku Honjo a few 2 years ago for the development of anti-PD-1 and anti-CTLA-4 antibodies for clinical use. But as you can see here as well, there is certainly a lot of room for improvement. And one of the ways we want to improve in my lab this curves and to increase the blue curve here to a higher percentage of survival, we try to target, as I said, this interaction between sialic acid containing sugars or siloglycans with Siglec receptors. And I mean, some of you might work on glycans, I guess. So, I mean, it's not, I don't have to convince you that glycans are important, but as you can see here on the surface of a lymphocyte, you can see this dense array of structures here with this electron micrograph in this electron micrograph. And what you can see is that this is really, the whole surface is covered with this glycocalyx. And you could imagine that any interactions of this lymphocyte with any cancer cell that has also glycocalyx is really influenced by this dense array of glycans. If we zoom into this comic here, and we have this this nomenclature here with this structures of glycans, what you can see here is on glycolipids, O glycans and N glycans on the cell surface are also secreted glycoproteins. You can see that most of them in mammalian on mammalian cells are actually terminating by this rhomboid structure, which is sialic acid. So mammals have a glycocalyx that consists of a high density of sialic acids. And this sialic acid in the physiological healthy state can actually be engaged by this sialic acid binding immunoglobulin like lectins or Siglecs. And Siglecs, as you can see here, they look very similar actually to PD-1. They have a ligand binding domain, which is here a carbohydrate recognition domain. Then you have some C2 domains, and then a transmembrane domain, and the intracellular signaling domain that has ITIM or ITIM-like motifs that upon clustering or activation of this receptor and binding to these sialic acids here can be phosphorylated by Src kinases, and this phosphorylation leads to the recruitment of SHP1 or SHP2 phosphatases, similar to engagement of PD-1, PD-L1 upon PD-L1 or PD-L2 binding. So this SHP1 and SHP2 can usually then inhibit T cell, or not only T cell, also immune cell activation in general, similar to other immunomodulatory receptors. Compared to PD-1, PD-L1 interactions, however, Siglec receptor family is quite complicated because there are 14 different functional Siglecs in humans, and we differentiate between two main groups of Siglec receptors. We have some so-called conserved Siglec receptors, which are conserved between different mammalian species. So we have it in mouse and in humans, for example, Siglec-1, which doesn't have actually a signaling intracellular domain. We have Siglec-2, which is quite well known as CD22, or a B-cell marker that is also targeted in cancer, because it's also present on B-cell malignancies. For example, we have Siglec-4, which is mainly expressed on myelin sheets in the brain or on nerves, and Siglec-15, which is also a conserved Siglec. And Siglec-15 you might keep in your mind. This is a quite interesting Siglec because it has already been targeted in clinical trials now for cancer immunotherapy. And then besides this conserved Siglec family, which is a smaller family, you have a larger CD33 or Siglec-3 related Siglec family. And as you can see, there is quite a difference between humans and mice, because this Siglec family has quite rapidly evolved during human or during mammalian evolution. And what you can see is there's a lot of different Siglecs in humans. You have Siglec-3, Siglec-6, Siglec-7, 8, 9, 10, which are all inhibitory Siglecs. And then you have Siglec-5, 14, which are paired receptors. So Siglec-5 has very similar, the first two domains are very similar to Siglec-14 and bind to the same ligands, but Siglec-14 is actually inactivating Siglec that can activate immune cells. Similar to this is also Siglec-11 and Siglec-16. And as you can see, also in mice, usually those Siglecs, they don't have numbers anymore because there's no direct ortholog. These are rather paralogs or functional homologs in mice. So the main Siglec on myeloid cells, which is broadly expressed in mice as well, is Siglec-E, and this is very similar to Siglec-9 because they have similar binding properties, and we often use Siglec-E knockout mice to study Siglec-9 in mice. So I will come back to that when I show some experimental models. So as I already started to mention, Siglec receptors are their physiological function is to give self-recognition and to keep immune homeostasis. So as you can imagine, that all the cells in our body have sialic acid or sialoglycans on the surface. They can engage Siglec receptors and keep immune cells in a healthy environment quite quiet. So, and then what you can also see in this graph, you can see that there can be cis interaction on the same cell. So, for example, on the same immune cell, or you can have trans interactions. And this might also play a role how well Siglec receptors can be engaged by, for example, cancer cells that upregulate the density of sialoglycans. So what several groups have shown during the last years is that tumor cells can upregulate sialoglycan density in a tumor. So what we know now is that sialoglycans are upregulated on tumors in the tumor microenvironment, and this can actually lead to an engagement of Siglec receptors, and thereby immune cells are inhibited by this engagement of sialoglycans, and this could mediate as an escape or immune escape of cancer cells. So this could be similar to a PD-L1, PD-1 interaction. It could also mediate an immune escape mechanism in some tumors, obviously, not in all the tumors. So the first step so I will show you now some experiments that have been done to show this preclinically, obviously, and also to show, this is not only from our lab. I will always mention also the labs that have contributed to this knowledge we have right now. So the first step was then actually to show that sialoglycans or Siglec ligands are actually upregulated in different tumors. So, for example, on the left side, you can see from experiments that we have performed at Ajit Varki's lab, we have done some staining for Siglec-9 ligands in this case, because we think Siglec-9 is very broadly expressed and might play an important role in immune evasion. We have looked at Siglec-9 ligands by staining with Siglec-9 Fc here in blue, and we found some staining in colorectal cancer, prostate cancer, quite strong extracellular staining, breast cancer, and also non-small cell lung cancer, compared to control, which was Siglec-9 that cannot bind sialic acid anymore. And what we have also looked at the infiltration of Siglec-9 positive cells or immune cells. In some instances, we have quite a strong infiltration of mainly myeloid cells that express Siglec-9, but as well we'll show later, also some T cells can express Siglec-9 in those tumors. At a similar time, Stefan von Gunden's lab in Bern, also in Switzerland, has reported on the staining with Siglec-7 Fc or Siglec-9 Fc, so staining for Siglec-9 and Siglec-7 ligands. He could show that there is an expression of Siglec-9 and 7 in melanoma, also compared, for example, to more benign tumors such as basal cell carcinoma or squamous cell carcinoma of the skin. So we can see that here in those two stainings, the melanoma has a stronger staining than, for example, in more benign skin tumor types. Natalia, who is also on the call, some of you might know her, is also performing some staining at the moment. So she did some tissue microarrays and then digital pathology analysis. So this is non-small cell lung cancer. And as you can see that compared to adjacent tissue, where you can also see some staining, there's quite an increase in staining of the different tissues. A bit less, to a lesser extent, Siglec-9. Certainly Siglec-7 was strongly associated with staining, but we also can see some Siglec-9 staining. And we're currently looking at different tumor types to see which tumor types are mostly affected. So this is also summary, for example, what Natalia has done, that, for example, in lung cancer, we find Siglec-3, 7 ligands quite prevalent, and Siglec-9, for example, in 75% of the cancer, we find Siglec-9 ligands. It's a bit less for in colorectal cancer for Siglec-3, but there's also Siglec-7 and Siglec-9 staining in colorectal cancer. What another PhD student has done in our lab, as Michael Stanczak, who left now, has looked at the presence of Siglec-9 ligands and the correlation of survival. And he has used renal cell carcinoma, and metastatic renal cell carcinoma, has looked at the staining here, a strong staining of the course in the TMAs, or strong presence of staining of Siglec-9 versus low staining. And he correlated with the survival, and he found that actually the survival in this instance for renal cell carcinoma staining, he found that the better survival he could see in those patients, and the higher staining he had, he could see a lower or a worse prognosis for those patients. So there's also an association in some instances, not in all cancers we looked at, but there's also an association of the prognosis of the presence of Siglec ligands in tumors with the prognosis of the patient. Okay. So this is nice. This is a correlation. We don't know if it has functional relevance, obviously. So several groups have looked at if sialoglycan interactions with Siglec receptors can actually inhibit immune cell function. So I will show the different experiments how they have shown that, at least in preclinical models, binding of sialoglycans to Siglecs can actually inhibit immune cell activation. So one of the first experiments involved NK cells. So there were also 2 labs involved, and NK cells express mainly Siglec-7. They constitutively express Siglec-7, inhibitory CD33 related Siglec, but they also express, some of the NK cells also express Siglec-9. And one of the first papers that showed that Siglec-7 and 9 interactions with sialoglycans on the target cell can inhibit NK cell activation was the lab of Caroline Bertozzi at Stanford. And they published, they used quite a nice method. As you can see here, they introduced high density of sialoglycans into the target cell by adding a synthetic sialoglycan actually into the target cell. And what they could show, if they put in this sialoglycan, they could actually inhibit NK cell activation by engagement of Siglec-7 mainly receptor. And on the opposite, when they used silidase treatment of the target cells, they could actually hear MCF7 as a target cell on the right side, HE29 colorectal cell, like killing by NK cells if they use desilidation of the tumor, of target cell or tumor cells in this case. A similar experiment was performed in also in Stefan von Gunten's lab, as I mentioned before already, and this is from the same paper where he showed that melanoma cells have a lot of Siglec-7 and 9 ligands. He could show when he blocked Siglec-7 receptor or Siglec-9 receptor, the blocking antibody could actually increase killing, or here in this case degranulation or upregulation on the surface of CD107A on the NK cells, showing that Siglec-7 and 9 interaction with sialoglycans can actually inhibit immune cell or NK cell activation. So this was interactions, sialic acid interactions with, or sialoglycan interactions with Siglec-7 and 9 on NK cells. Joy Burchell's lab at King's College and Richard Beetson, as a PhD student at that time in her lab, did experiments with macrophage and monocyte, and this was published in Nature Immunology in 2016. This is so they found when they UCN1 that contained STN antigen, so TN antigen on the surface compared to MUC1 that didn't contain this sialoglycan. they could see that they had a polarization actually towards an M2 phenotype of these human macrophages, which was measured here by CD206 upregulation. And they could also find they could increase some PD-L1 expression on this MOC1 ST treatment of the macrophages or monocyte-derived macrophages in cell culture. So when they also block now with Siglec-9 antibody, they could actually reverse this phenotype. So they could reduce again CD206 expression by adding the adding Siglec-9 antibody, showing that interaction between siloglycan with Siglec-9 can actually lead to an M2 phenotype in macrophages, and this could then promote tumor progression. Although they have not shown it in vivo in a good in vivo model so far. Last year, also from Stanford lab, Irv Weissman's lab, who has described the CD47 alpha interaction as a don't eat me signal in cancer, and they're targeting now CD47, they could show that the interaction of CD24 or glycosylated CD24 on the cancer cells with Siglec-10 on macrophage could also act as a don't eat me signal. So this could also inhibit macrophage phagocytosis, and when they then blocked in vitro, at least with an anti-Siglec-10 antibody, they could then increase the phagocytosis of target cells. So this interaction, so actually not only M2, M1 polarization could be influenced by siloglycan Siglec interaction, but also phagocytosis could be affected by this interaction. So we have macrophages and K cells, and our lab has recently shown that also on T cells, and mainly on tumor-infiltrating T cells, Siglecs can also be upregulated. And this is quite interesting because, as you can see here in normal PBMCs from a healthy donor, there is really a very small population on CD8 T cells here that express Siglec-9. If you look in a patient with non-small cell lung cancer, you can see that there is already in some of the patients in the blood, there is a population upregulating Siglec-9. And if you look in tumor-infiltrating lymphocytes, CD8 T cells in the tumor, you can find that in some instances, it's quite heterogeneous, but in some patients we can find quite a strong population, a quite clear population of CD8 T cells that express Siglec-9. And we also looked for other Siglecs. So this is from effects. This heat map is actually showing effects analysis of different patients. So the numbers here are different patients. And we looked at Siglec-9, 7, 10, and 5. And basically Siglec-9 was the most consistently upregulated in our hands. We had also in some patients, we had also some Siglec-5 or Siglec-10 present on CD4 and CD8 T cells on tumor-infiltrating lymphocytes. This is all non-small cell lung cancer. So we then asked if this upregulation of Siglec-9 inhibits T cell activation. And for this, we produced target cells, for example, lung cancer target cells IA549, where we knocked out the rate-limiting enzyme for salic acid biosynthesis. This is glucnac epimerase or GNE. And if you knock this GNE out, you can see here with Siglec-9 FC binding showing the Siglec-9 ligands in a wild type. You can see if you use silidase, so you remove the salic acids by treatment with Vibrio cholera silidase, you can really decrease the Siglec-9 ligand density. Also, if you look here at the GNE knockout, you can really see a decrease. And the nice thing in vitro, we can actually refeed the cells with salic acid in a cell culture at least, and then we can, even in the knockout cell line, so this is the refed cell line, we can actually increase the salic acid density on or siloglycans again and the Siglec-9 ligands. And we did the killing assay here using a trick, because usually T cell receptor-mediated killing, you need T cell clones that really recognize the antigens on a target cell. But here we used the trick. We used EpCAM that binds a bispecific antibody that binds to EpCAM on the tumor cells and CD3 on the T cells and activates T cells. And we could see that we could increase apoptosis by measuring cleaved caspase 3 in those tumor cell, the A549 tumor cells, when we decylated, or we used the GNE knockout cell line, and when we refed, we could revert this phenotype actually in the assay. I introduced the GNE mainly also because we used it then in vivo in urine models where we had syngeneic models where we knocked out, in, for example, MC38 cell lines, we knocked out the GNE and we could see that there is a really delayed tumor growth in the MC38 model, but also in a BALB/c EMT6 orthotopic breast cancer model, we could see a strong delay of tumor growth, although the cell lines were growing quite similarly in cell culture. What you could also see if we overexpress Siglec-9 on T cells in the MC38 model, subcutaneous tumor growth, we could see that if you overexpress it on T cells, we could see an increased growth. And we also could see, and some of the data is not yet published, so I did not go everything into this publication. So when we did induced with carcinogen methylcholanthrin, if we induced tumors subcutaneously in black 6 mice, we could see that the tumors appeared earlier if we overexpressed human Siglec-9 on T cells. So Siglec-9 seems to play a role on T cells as well. And lab who actually found PD-1 as a live or PD-1 described this as a potential target. His company and this lab in Yale actually found by a screen where they looked at inhibitors of Jurkat activation in vitro, and they screened actually 6,500 genes. They found Siglec-15 as a strong inhibitor of T cell activation. And what they then made, they made a Siglec-15 blocking antibody. And the nice thing is this antibody is recognizing human and mouse Siglec-15 since it's a conserved Siglec. What you could see here, they could also delay tumor growth, and this was published in 2019 in Nature Medicine. And they're also already running clinical trials with this blocking antibody. So to summarize this part, the Siglec-Siglec interaction involves both innate and adaptive anti-cancer immunity. So you can actually target NK cell interaction, T cell interaction, also interaction with myeloid cells. So the last part will now talk about how we can target this interaction to bring compounds into the clinic and really test if this pathway is really important in patients. So there's basically 3 ways you can target this interaction. So one of the ways you can do that is it's quite simple and similar as it was done with blocking antibodies for PD-1 or other immune checkpoints that are set now. So you can just block the Siglec-9 or Siglec-15 or whatever by blocking antibodies. So you can block this interaction. Another thing is you can remove the sialic acid by a sialidase. So one approach is to use a tumor-targeted approach where you can have an antibody, for example, against HER2. So you use trastuzumab, you link it to a sialidase, and then you can basically remove sialic acid from the surface of the tumor cells, but also from the tumor microenvironment. And then a last approach is obviously to use small molecules that could, for example, inhibit the synthesis of sialic acid, which can be mimics, for example, of sialic acid. The problem here is that the ones which were tested so far are usually quite toxic. So, for example, there are many GNE inhibitors, but they can be barely used for cell culture, and it's very difficult to use them in animal models. So it's hard to develop these inhibitors. So I'm not so sure if this can advance. But another option to use small molecules could also be small molecules that block, for example, different Siglec receptors in the carbohydrate recognition domain. This could be also an approach. So in our lab, we're also using one of these approaches. So we have done in collaboration with the company some Siglec-9 antibodies. So we used here to screen these antibodies. We used the cell culture model where we used the NK cell line that we stably transfected with Siglec-9. And as you can see here in the blue line here, you have the effector to target ratio. And you can see you can strongly, or you can inhibit NK cell activation by adding Siglec-9 on the surface, which is not new. Caroline Bertozzi has done that. Stefan von Gunten has done that. And as a control, we also used the mutant Siglec-9 that lacks actually the ITM signaling domain. So it still binds to it still binds to sialoglycans, but it's lacking the signaling domain. And you can see this is not working. And we then screened different antibodies, and you can see here some of the antibodies we used on the right side. They can increase really the specific lysis of this NK cell line, lysis of K562 target cells. We then also tested these antibodies in an in vitro assay if we can induce T cell proliferation. So this was done by Anne Bernwald in our lab. And we used here the model I introduced before, where we overexpress actually Siglec-9 on T cells. So this is the model where, going back, where you have transgene where you have a stop codon before the human Siglec-9 with a GFP, and upon crossing with the Cre line, you can actually remove here this fluxed part where you have the stop codon. You can also remove the GFP, and you have a Siglec-9 overexpressing mouse that expresses, if you cross it to the CD4 Cre, you overexpress it in T cells. And what we can see here is if we have here the Cre line on the upper row, and we do activation for 48 hours with CD3, CD28 beats that activate T cells polyclonally, and we look here at CD8 and CD4, the T cells do actually not proliferate, and they do very little express the activation marker CD69 or CD25, compared to the littermate control mouse that doesn't have Cre and does not express human Siglec-9. You can nicely activate and stimulate the proliferation of those cells. So here we could also use different antibodies. We use, for example, commercially available R&D antibody, blocking antibody, and you can, by using here this blocking antibody, you can actually induce proliferation. And by this, we could actually measure different antibody clones. Maybe I have to skip that a bit quicker because it's quite confidential, but we have patented the antibodies anyway. You can actually screen different antibodies, how they can induce T cell proliferation. So we have a few different T cell Siglec-9 clones that we're testing, and we're hoping to move that forward into clinical trials at one point. I also mentioned Siglec-15 antibody, and I also showed you some results, mouse results, and we have already seen some clinical results from the phase 1 trial that was run by NextCure, and we can see that mainly non-small cell lung cancer, we have in this phase 1 trial, we have people responding to Siglec-15 blockade already by monotherapy, which is very rare in early immunotherapy trials. And I will just move on to the next slide, where we see a patient that had actually a lung cancer. And we had monotherapy with the Siglec-15 blocking antibody, and we can see that this tumor here is actually shrinking by week 16 after the start of the treatment. So had a reduction of the volume of the tumor by 71%. So this is really quite impressive, because it's a tumor that it's a molecule that is actually having activity. Another approach that Caroline Bertozzi and we have worked with her together for this project developed is targeting sialidases to the tumor. So what you can do is, you can see on the right side here, and has recently been published in Nature Chem Biology. What you can do is you can actually, instead of blocking the ligand with PD-L1 here, you can actually cleave the ligands off by using a sialidase that is targeted to tumor. In this case, we used trastuzumab, which is trastuzumab sialidase 2. This is still a bacterial sialidase. It was a Salmonella basidase that Melissa Gray in Caroline's lab characterized, and sialidase then removes the sialic acid on the surface of the target cells, and by this, Siglec receptors are not engaged anymore, and the immune cell is better activated. And for some of these experiments, also Natalia has done quite some staining. For example, here we used some compounds we used together with Paleon, which is a company that Caroline actually founded. It's a Boston-based company, and they made then more active compounds, for example, trastuzumab, that has biotechnologically attached two sialidases here that cleave off sialic acids. And we have also used here a loss of function sialidase to compare. This is the same molecule, but the sialidase has point mutations, so that the sialidase is not working anymore. And if you look here at it, this is the full tumor here, mouse tumor, in the P16 HER2 model. So this is our P16 cell lines, PAX6 cell line that overexpresses human HER2. And when we treated here this mouse with E301, this molecule here with the loss of function, you can see that we have still a lot of cyclic ligands And if we add this molecule here after 72 hours, all these ligands are actually gone. So we can really efficiently decellulate those tumors. We then obviously also wanted to see if this has an efficacy effect. So we see some delay of the growth here of the B16 tumors subcutaneously when 4 times this compound was injected compared to the loss of function or trastuzumab as control alone. Obviously, B16 is quite aggressive model, as some of you might know, so it's a very rapidly growing, and it's also not very PD-1 responsive. We did also some other models here with other molecules. So, for example, a molecule where you have one arm of the antibody is a silidase and one arm is antigen binding part, PEP fragment, and you can then see that in this EMT6 model, which is in bulb C, which expresses also HER2, human HER2, we can see even with monotherapy, we could also see some rejection. So in this case, we had 3 out of 6 mice had a rejection of the tumor. And when we re-challenged those mice that had a rejection, we can see here that these mice did not grow again the tumor, showing this is really immune mediated. And as on the right side, you can also see that T cells were more activated. Here in blue is this eagle-treated mice. And we can see here in blue that there are more T cells, they are more activated, so they express more Ki67, so they proliferate more and they're more activated by expression measurement of granzyme B. So the next question obviously was, can you combine that treatment or decellulation with immune checkpoint inhibitors? And what Michael Stanczak as a PhD student then looked at, he used again the GNE model he developed, so MC38 GNE knockout, which have substantial less sialic acid on the surface of the cell membrane. And he combined MC38 GNE knockouts together with anti-PD-1 CTLA-4 treatment here in MC38. And we could see that there was a clear increase of the survival of mice, and we had 10 out of 17 were rejecting tumors. And the similar thing here in this experiment, he could also increase rejection in the EMT6 model, where he had only 4 mice rejecting with PD-1, rejection with PD-1, and 6 out of 12 mice with 6 out of 12 mice in this EMT6 GNE HER2 model. We also then combined not only the GNE knockout cell lines, but we used again the B16 HER2 model, and we combined here. This is quite a lot. There are quite a lot of conditions here. We combined the treatment of the silidase with PD-1 CTLA-4, and what you can see here is that this is really the most delayed curve here. So yes, the best survival of the mice here if we had a combination of all PD and the PD-1 anti-CTLA-4 together with the silidase, targeted silidase construct. And he also used here depletion of CD8, and he could show that if you deplete CD8 there, you have actually a real reduction of the effect of the silidase, showing that CD8 T cells are involved in this. So it's immune mediated. It's as also the re-challenge model obviously shows. And one of the next experiments was, is it really interaction between siloglycans that we remove by this treatment and Siglec receptors? And one of the main Siglec receptors is actually Siglec-E, and he did then a treatment with this silidase in Siglec-E deficient animals, and he could not see a big effect anymore, showing that there is most of the effects seen, at least in this B16 model, is mainly mediated through Siglec-E siloglycan interactions. There's certainly some other interactions when you remove sialic acid, because you also have galactose coming up. You have galactose binding receptors that could actually stimulate the immune system. So this is the exact effects we're still studying, because we believe it's not only CD8 T cell activation, we believe really there's myeloid activation and dendritic cell activation. Nevertheless, if you use in Siglec-E knockout mice, if you use immune checkpoint inhibitors, you can see that there is quite a strong delay and also much more rejection if you use anti-PD-1, anti-CTLA-4 inhibitors in Siglec-E knockout mice. So to understand actually the the immune mechanism of this delayed growth or of this effect, anti-tumor effect. We looked at different immune infiltrates quite early on after treatment. And what we found is that, for example, we had an increased activation here of CD11C dendritic cells. So we found the CD40 upregulation on dendritic cells, and we found also an increased activation, a subsequent activation of CD8 T cells in these mice treated with the active sialidase. So what we did then next, and these are just experiments that Natalia did recently, and we just came out with that, is that we knocked out Siglec-E in some subtypes of dendritic cells and phagocytes, and so we made a conditional Siglec-E knockout mouse where we can, has a flux Siglec-E, where we can knock it out by crossing them with the Cree line. And we crossed it with CD11C Cree, which has a knockout of Siglec-E on classical and all classical dendritic cells and also some macrophages. And XCR1 is a marker for classical dendritic cell type 1, which are involved in cross-presentation. And what we find is that the effect here in MC38 model is that mainly there is a delayed tumor growth if we knock out Siglec-E in the CD11C Cree members, so on CD11C positive dendritic cells or also macrophages. So we're quite sure that this is one of the mechanisms involved in this interaction, Siglec-E sialoglycan interaction. So we're studying this is also the reason why we study dendritic cells. So we have also done some stainings, and this is just giving you an overview of changes of Siglecs. And this is quite complex in humans. In mice, it's a bit less complex because you have mainly Siglec-E on these classical dendritic cells. But if you look in humans, you have many different Siglecs. So this is just summarizing FACS experiments that have been done. I don't show you the primary data, but there's a lot of different inhibitory Siglecs, for example, on CDC1s or CDC2s here. There's Siglec 1, 9, 5, 8, and so on. So this is quite a complex story. So I think it's probably easier to remove sialic acid than blocking any of those Siglecs on dendritic cells in cancer patients. And Jean Liu, who is a PhD student in the lab, he is actually looking at, since we didn't find so much difference in XCR1 Cree mice, which would be specific for classical dendritic cell type 1, we actually are looking more on CD4 T, so CDC2s and CD4 T cell stimulation. So what he found is that if we, for example, overexpress Siglec-9 in a mouse system on dendritic cells in a bone marrow derived dendritic cell model, and we look at OT1 proliferation once that we stimulate the dendritic cells with ovalbumin, we can see that there is a decrease in proliferation of OT2 cells, as you can see here, and also a decreased activation of OT2 cells in his experiments. And we believe that the Siglecs play quite a role also in classical dendritic cell presentation, and maybe also CD4 T cell stimulation, but this is certainly ongoing research, and it's quite early to definitively know what's going on. So I'd like to summarize the presentation, and then obviously I hope there are some questions. I hope I could show you that Siglec axis is a new immune checkpoint that could be exploited for cancer immunotherapy, and targeting of sialoglycan Siglec axis can potentially activate both innate and adaptive immune cells. We have some first antibodies that are used in clinical trials that target Siglec receptors and are quite promising. And I think one of the very promising approaches is to really remove the sialoglycans in the tumor to actually have not this complication of having so many different Siglecs and you don't know exactly which one you have to target. So one of the approaches that will hopefully move to the clinics quite soon as well with Palamon Pharmaceuticals in Boston with an antibody sialidase construct, and we will see if this was really an interesting new approach to improve anti-cancer immunity. So I would like to finish by thanking all the people who did the work. This is quite a recent picture, so at least we can still go hiking without masks. This was in summer where we had quite low case numbers of corona. Now we would have to wear probably all face masks as well again. And you can see my group, and obviously you can see the main collaborators for all of those projects. And obviously, I also would like to thank the funding agencies who helped to make this research possible. And I hope you have some questions, and I'm looking forward to them.
Thank you, Dr. Lawley. Nice work, very nice presentation. Just to start with a question, I was wondering when you mentioned the trial in monotherapy, and then you mentioned the trial with a combination with another immunotherapeutic. And then I wonder what's your opinion about combining with immunogenic chemotherapy and radiotherapy, which eventually release dumps and could like foster this kind of, this is already being done. This is already now in clinical trials with anti-PD-1 and anti-PD-1. So I wonder if you think these strategies targeting Siglec could be combined with chemo and radiotherapy.
Yeah. I mean, obviously with PD-1 inhibitors, it has been done. It's also approved for lung cancer, for metastatic lung cancer, for example, or head and neck cancer, for example. We have combination therapies with PD-1 inhibitors and chemotherapy, and I think this could be certainly another approach you could imagine. And we haven't tried that. That's a good point. I mean, this is something could easily try. I think in the end, there's many combinations you could try. I mean, radiotherapy is also something one could discuss. I mean, radiotherapy, to have immunogenic radiotherapy, I'm not completely convinced yet that this really works. In clinical practice, I have never seen any patient myself. I mean, there are published case reports on immunogenic radiotherapy and abscopal effects. So I would rather bet on chemotherapy interaction. But I think first, I mean, those trials have to show real efficacy in a larger cohort of patients to show that these are really compounds that make sense to use them. And then obviously you can start thinking of combining them with either immunotherapy, chemotherapy, or even targeted therapy, as it is also done, for example, for renal cell carcinoma with axitinib, pembrolizumab, which is approved as well for treatment of cancer.
Okay. We have questions here in the chat. The first question is from Luisa Abdo, who is a PhD student. She's saying, great presentation, thank you. Have any side effects been observed in animals treated with antibodies against Siglec?
With the Siglecs, I mean, not the ones we treated so far, but these are all short-term treatments. I mean, I know that some companies have done obviously long-term treatments, especially also companies that have other Siglec-9 antibodies. I don't know that the data hasn't been released, so I don't know how long-term treatment would be a problem. With the Silidase treatment, we had some side effects, obviously, because the Silidase is not so specific, even if you target it to HER2, because we see also some decylation of the liver or the kidney. It's not unlikely that you will have some side effects, but then Pauleon has done quite a lot of toxicity studies to move forward into the clinic. So they have done some rat toxicity studies, and also non-human primate toxicity studies. I haven't seen the original data, but I've heard that they were not so bad. I mean, they had just raised $100 million to move their program into clinical trials. So I think it's quite convincing data also from the toxicity side that you can actually long-term treat animals with these compounds. One other thing we have also observed in mice is that if you decellulate, for example, platelets, which also happens, you see a drop of platelets because you have also the glycoprotein receptor and so on that in the liver and spleen you have receptors that recognize decellular blood structure. So we see a slight drop of thrombocytes or platelets in our animals, but it was never a problem that we would have seen any bleeding, or it never dropped so far that was a big problem.
Microphone, Gabi.
Thank you. We now have two questions from Adriane Todeschini, which I think you already know.
Yes.
Adriane? Yes. Okay, she's asking, can you inhibit the binding of Siglec-7 or 9 by using the molecule Siglec-7 or 9?
So you would use a bait, kind of a bait similar like it's used for TGF beta, for example, in clinical trials.
Yeah, the ligand. The ligand.
Yeah. I know a company that has tried that, and they have quite interesting, for Siglec-9, quite interesting in vitro data. We have never tried it, I have to say, but it's a good option, and it seems to have some in vitro effects. I have not seen any in vivo data, and we have not tried it in vivo, but it's a good idea.
Okay. Adrienne, in case you want to open your microphone, please go ahead. And the other question is, can you deliver GNE inhibitors by using anti-PD-L1 or trastuzumab?
Yeah, GNE inhibitors have been developed, for example, by Horst Korte in Germany, which are chemists. They are chemists, and I mean they have tried it in cell culture models, and they are already quite toxic in cell culture models. We have not dared to try it in mice. I think there is a paper from Adema, Gossi Adema in the Netherlands, and they had used sialic acid mimetic that actually inhibits the sialic acid synthesis of fluoridated sialic acid. And they could also inhibit sialic acid synthesis, but they had to inject directly into the tumor of the mice. So I'm not sure about, And they have seen also T-cell activation by that and decellulation. This is a cancer research paper. I haven't mentioned it, unfortunately. I should have mentioned it as well because it's quite a nice paper. I'm not sure if this is something you would want to go into a clinical trial with humans. I'm a bit afraid of the toxicity of those compounds, of those small molecules I've seen so far. That doesn't mean I'm not a chemist. I mean, that doesn't mean that it's not possible to do it. I mean, I would be open for it. But I mean, at the moment, I'm not sure if there's a good small molecule that can, for example, use GNE. I mean, one of the things that could be used is like the nanocarriers. Maybe this was the question as well, that you target nanocarriers to trastuzumab coupled to immunoliposomes, for example, targeting HER2, you could transport it, but it's very complicated to produce those immunoliposomes and so on. So I think it's not the first approach I would use, but I mean, it's not as clear that this works.
Okay. She said that she doesn't have a microphone at the moment. So.
Okay.
Okay. Now we have a question from Julio, who is also a glycobiologist in our institute. He says, first of all, thank you very much for the excellent talk. I would like to know if you have also tested the remodeling of cyelination using fluorinated analogs of sialic acid. And if you believe that this strategy can be used in some context, or if you consider it to be a strategy that is too unspecific.
I mean, he's right now also referring also to this work that Gossi Adema has done. I think because they have used this fluorinated analogs, and I mean, I think it's possible. I think you would need to formulate it somehow into liposomes or to systemically deliver it, or one could even think to inject it locally, but then you could also think of injecting locally some other substances like sialidase directly. I mean, this is something people have tried so far. I don't think it's too unspecific. I think for probably using it as systemic approach where you give it intravenously, you would need or want to have some targeting, because I think otherwise the toxicity might be too strong, I guess. But one has to try. I mean, we haven't tried, I have to say.
So Heinz, can I ask you a question too? I have a couple of questions, but
sure.
Can you see me?
I can hear you, but I don't see you. That's fine.
Oh, can you see me now? Thanks for the great talk. And I was wondering if there's a crosstalk between Siglec signaling and PD-1, PD-L1 signaling pathways. In other words, can tumor decellulation also benefit the PD-L1, PD-1 blocking checkpoint?
Yeah. I mean, we haven't exactly looked. Yeah, we haven't. I understand the question. I mean, we haven't exactly looked at modulation of expression or signaling of PD-L1, right? I mean, one could do that by using decelerated target cells or so on. I mean, we haven't looked at that, but what from the clinical, at least from the mouse models we used, we see some additive effects, because we see if we decellulate, we see an additional effect if we add also PD-1 or CTLA-4 inhibitors. So at least for PD-1, we see some additional effects. I wouldn't say it's synergistic, but I think it's certainly additive in the mouse models. But the exact mechanisms we haven't studied, right? How this works, and it's actually interesting, because I don't think, in my opinion, I mean, I put it simple, mainly also for MDs, which I'm talking a lot to. I don't think it's only Siglec interactions, Siglec sialic acid interaction. I think the decellulation obviously has much stronger impact. It also, you have all the galactose coming up. There might be also some mannose binding receptors on myeloid cells that get activated. So I think this is probably more the mechanism, even if we sell it at the moment as this interaction. So I think the data point,
This was another point I wanted to hear thoughts. I mean, if you can share some. It's also, if you decellulate tumors, you probably generate epitopes for galectin bindings, and they can promote tumor growth, vascularization, apoptosis, and so on. Do you think it's also a point to consider, like adding a galectin blocking step, like one more step when you try to do glycoimmuno checkpoint inhibition?
Yeah, I think in the end one has to. I mean, I think as a clinician, I think, of course, we have to somehow understand the molecular function. But I think the next step is also to move it forward into the clinics, because I mean, without having human patients figuring out which one will benefit and which one not, it's too complicated. I think we can very long wait until we find models that show you the opposite or show you. I think it's important to understand the biology behind it. I can see that, but I think we have quite some evidence that targeting at least the siloglycans can really strongly can have a strong effect on tumor growth, at least in murine models. And I think we should try it in humans. In human patients that have no options, obviously, otherwise then so this will be phase 1 trials, and then I think from that, obviously, we need to work on it and to learn how to understand, and also understand the exact mechanism, which patient will benefit. Is it only the patient that have a high amount of sialic acid already in their tumors, or is it maybe also patients who have a normal amount of sialic acid, and which even removing there, it could have a benefit? I mean, Pauleon at the moment believes that they should target patients only with high siloglycan content, so they do some staining. So we do some staining with them for the siloglycans, the tumor biopsies. But I'm not sure if this will be a good biomarker. I mean, we will only learn if we see patients that respond versus patients that don't respond. If no patient is responding, anyway, we don't have to think anymore, right?
Right. Thanks, guys.
Okay. Martin wants to take
Can I
away.
just ask a quick question from YouTube, quickly?
Yes.
It's quite in line with the first question from Gabi and from like the combination therapies you were discussing. Eduardo Manarino Correa is asking if you think it can be combined with CAR T therapy?
This is a good question. Especially decellulation has been tried also by Avery Posey at UPenn, who is a former postdoc of Carl Chu's lab. And he has also made some CAR Ts that overexpress actually sialidases, and he can see some increased effect. Actually, Natalia has also done some experiments using the GNE knockouts, and we see an increased killing, but of CD19, for example. So we use Ramos as a target cell that lacks the GNE, and we have used that, and we have seen an increased killing in vitro. At least we haven't done in vivo experiments, but Avery is working quite strongly on that at the moment, so we stopped a bit to not have too much overlap there. But I think depending on we have some ideas there as well, but but I think it's certainly an approach you can consider. I mean, similar to PD-1 targeting together for solid tumors with CAR T-cell therapy. I think this could be an option, but I think, yeah.
Thanks.
Go, Martin.
Okay, so thank you very much. Wonderful talk and wonderful set of data. So it was very interesting to discuss this. My question was a little bit more, a little bit related with Fred's question on combination, but looking more on the inner side of the cell in terms of the signaling domain. So you mentioned that you have the ITs and different additional domains, not like the ITSM that you find in the PD-1. So you probably are engaging different downstream paths, even though you just mentioned SHIP1 and SHIP2. So what do we really know about how this downstream signaling happens, and what happens on T cells, on NK cells, on DC? Because it's not that clear to me in terms of what goes downstream on signaling. And in line with this, and a little bit linked to Luis's question on the side effects. So, do you maybe that we could have some hubs on these signaling pathways that could maybe block just on the conversion of PD-1 and Siglec and whatever.
This is a very good question, and if I would know exactly the signal, downstream signal, I would like to tell you. I think what we learned also from example from Jim Paulson's experiment that has a long history on CD22 B cell receptor signaling, and also recently published a paper on IgE on mast cells and Siglec3 CD33 signaling. I think what we certainly know at the moment that many of the Siglecs only work similar to PD-1. Probably they're recruited to the immune synapse or to the and actually inhibits the downstream signaling. But the thing is, I mean, for example, for T-cell, it has been done for some experiments have been done. So it's shown that NFET downstream signaling is inhibited by Siglecs, but always in very artificial systems, because obviously it's not so easy to have no salicylic acid on the surface. So or you remove salicylic acid on the cis interactions, but not on the trans. So it's not so easy. So for me, I don't also exactly understand. I mean, I think for T cell receptors or also NK cell activation, it's quite clear. You have an immune synapse, so that the NK cell recognizes somehow by lack of MHC or by activating receptors on the target cell, the NK cells gets activated, and there's immune synapse, and then NK cells are the signaling receptors are actually recruited to this interaction site. But I'm not even sure. I mean, it's always drawn also in like the Nature Chem Biology paper that Caroline Bertozzi recently published together with us. It's drawn as there is a trans interaction, so the Siglec binds in trans the target cells. I'm not 100%. We have so many experiments which actually don't support that. I didn't show that because I don't understand it at the moment exactly, but I think it's not. I'm not sure if it could also be that the Siglec receptors actually bind to sialic acid-containing parts of the signaling domain of on the immune cell itself, and are recruited.
Right.
Yeah, it's this. Yeah.
So this has been shown
that,
also for PD-1, for instance, right?
Yes,
They have several other ligands, and in Cs and Ks, it's a big
yeah,
nowadays, right? So this could be the same for the Siglec.
Could be the same. Yeah. I mean, I'm certainly not a specialist in signaling, so I'm probably not the best person to ask about all the downstream signaling. I mean, we have some projects where we look at T cell receptor signaling. We have some models. That's where my statement comes from. That I'm not sure. It's probably rather interactions on a cis interaction very often on the T cell receptor together instead of having a trans interaction. And then maybe the removal of sialic acids is not directly, maybe the increased killing by T cells is not only Siglec related, because we had really, in our paper where we showed Siglec 9 overexpression on T cells, stills, we had really big trouble to show that we can revert this by blocking Siglec receptors, for example. So I'm not, I don't think removal of sialic acids is only going through Siglec receptors. But it's always difficult if you don't have a good answer and you want to publish something. At least you have to show the experiments and hypothesize that it goes this way to convince, to have a story at least. But I mean, I'm not convinced that this is the only way.
Thank you very much. Thank you.
Dr. Lau, I need to apologize for my noisy fan already. Before we can move to the next question from Patricia.
Adverse events in patients. If you have any idea or any evidence of what you would expect, considering that for some immune therapies like combination, right, of CTLA-4 and PD-1, you have quite important adverse events. And I was wondering if you have any idea on that.
Yeah, I mean, for Siglec 15, we had seen when they present, I mean, there's no publication yet. So the Siglec 15 that was just presented at the SAITC meeting 1 year ago in Washington, and they showed some slides of the ongoing trial. So I mean, it seems quite safe. There were some gastrointestinal problems, but very often seen, and some skin problems. But it's not. It seems quite safe at the doses they used, and they've seen some responses. I mean, for the other things, I mean, for Siglec 9, it could be you could have some activation of myeloid cells. Or, I mean, this is possible, which could then lead to like cytokine release syndromes or hemophagocytosis syndromes, which would probably prohibit the pursuit of such an antibody in further clinical development. But this has to be tried, obviously, at early stage to see if this is because you have a lot of neutrophils and also monocytes in the circulation that actually express this Siglec 9 receptor. And with sialidase, I mean, as I said, we have seen quite some strong decellulation of the kidney and also of the liver. So my fear is a bit that you will, I mean, since the glomeruli filter is really dependent on sialic acid to keep positively charged proteins into the bloodstream, I'm a bit afraid that you might induce some nephrotic syndrome where you lose proteins and you can damage the kidney. I mean, they have supposedly not seen it in the non-human primates trials, but we will see what happens if they go into patients at one point. And the same is true, obviously, for liver enzyme changes. We also measured some liver enzymes in our animal models, but we have really only had short-term tumor models where you have like maximum 4 weeks or something. And we did not see too much changes, and I think that's something one has to keep in mind if you decellulate the liver or you decellulate as well. I mean, you could also have, as expected, I think, a drop of platelets. This is certainly be seen. Well, if this is possible to do it systemically as sialidase treatment.
Thank you.
No more questions. Let me just check on YouTube. No, it seems that we're done with questions.
No, yeah, we're done.
Okay,
Okay.
great. So it's summer in Brazil, huh? Yeah, here it is.
Yeah, it's quite warm.
Yeah, yeah. Okay.
So I'd like to thank you, Dr. Laubli, for promptly accepting our invitation to be here and to discussing your data with us and taking part of your time to give a talk for us. Okay?
Thank you very much also for the invitation. And it's Friday evening. I mean, I have nothing better to do right now because everything is closed anyway in Switzerland because of the COVID. Okay. No, thanks a lot. And
Okay.
bye-bye.
Before we finish, we just need to give some quick announcements in Portuguese. So in case you need to leave, please go ahead. Don't worry, okay?
If you don't need me anymore, that's fine. I will leave.
No, it's fine.
I will wish you a good weekend and one.
Okay, you too.
Bye.
Have a nice weekend.
Bye.
Bem, pessoal, chegamos ao último seminário do ano e caso a comissão queira abrir as câmeras e os microfones, fiquem à vontade, a comissão organizadora de seminários. A gente queria só falar um pouquinho com vocês antes de passar a palavra para o Marcelo Soares, que é o coordenador e vai fazer o encerramento dos seminários oficial. A gente queria dizer que a gente sabe que esse ano foi bastante complicado e nós da comissão tentamos extrair o melhor que a gente poderia do formato online, né, que é convidar pessoas de fora do Rio e de fora do Brasil, que de outra maneira não seriam, a presença não seria tão simples, né, aqui nos nossos seminários. Então, eu espero que vocês tenham gostado, que vocês tenham usufruído dessas palestras. A gente gostaria de agradecer muito a toda a equipe envolvida, a equipe da comunicação social, principalmente a equipe da videoconferência, ao Alain, Paulo, Carlos Henrique, que foram sensacionais no suporte às palestras e a todo o suporte antes do evento, na organização de tudo desde o início. Então, assim, eles são sensacionais. Eu tenho certeza que eles são uma das pessoas que estão mais trabalhando durante a quarentena. Tá? E gostaria, por fim, de agradecer a vocês, né, pela participação, pela interação com os palestrantes, por fomentarem as discussões, por entenderem os problemas técnicos que nós tivemos em várias palestras, conexão dos palestrantes, problemas até aqui da plataforma, que foram mais raros. Agradecer por vocês terem aderido bem a esse formato, e a gente não sabe como é que vai ser no ano que vem, então a gente espera que, se for, que ele tenha funcionado para vocês, que vocês tenham curtido. Tá? Então, é isso. Aqui está a comissão, a Andréia, a Bárbara e a Patrícia e o Fábio, que não pôde estar presente. Agradecer a eles também pela parceria, a gente trabalhou muito bem esse ano juntos, e eu espero que vocês tenham gostado desse novo formato. Ok? Então, eu gostaria de passar a palavra para o Marcelo Soares, para que ele faça o encerramento dos seminários.
Boa tarde a todos. Obrigado, Gabriela. Bom, em primeiro lugar, eu acho que eu queria parabenizar, obviamente, mais do que a qualquer um, os membros da comissão, né? Você, a Gabriela, a Patrícia, a Bárbara, André e o Fábio, pela desses seminários, desse ciclo, né, de palestras, em formato aí novo, desafiador, né? É importante ressaltar que acho que foi por intermédio de vocês que a gente, de fato, começou a tomar coragem, inclusive, né? Eu estou falando já do ponto de após iniciado, quer dizer, o ciclo de seminários foi o primeiro, vamos dizer assim, dentre as disciplinas, a primeira a ser iniciada, e com base nisso a gente, então, realmente teve uma compreensão maior da viabilidade disso acontecer, e aí começamos a implantar as outras disciplinas, que muitos de vocês aí na audiência estão fazendo ainda, né? Ou já fizeram. Então, assim, mas eu acho que o ciclo de seminários foi realmente uma fagulha, o gatilho importante para a gente mover para esse processo, que, de fato, eu acho que vai ser, infelizmente, vamos colocar assim, né? Apesar do sucesso, acho que a gente ainda vai ter que enfrentar isso aí, talvez por mais um semestre, pelo menos, né? O que tudo está indicando aí em termos de epidemia, né? Então, assim, é importante a gente já ter essa experiência e eu acho que foi excelente. Queria parabenizar todos daí da comissão, queria parabenizar aos alunos aí pela paciência, por ter compreendido essa necessidade e aderido, né, a esse processo, né, e também destacar, como a Gabriela falou, né, que, na verdade, isso nos traz, embora tenha sido desafiante, né, desafiador a princípio, mas nos trouxe também outras características, outras vantagens, vamos dizer assim, desse sistema, né, que vocês puderam acompanhar aí ao longo desse semestre de apresentações. A gente teve aí várias apresentações estrangeiras, né, de pessoas, colaboradores ou não, do grupo, pessoas, pesquisadores eminentes de várias instituições, dos Estados Unidos, da Europa, né, e de outros lugares, e de outros estados do Brasil também. Quer dizer, a gente teve uma oportunidade de ampliar esse espectro aí de pesquisadores de alto gabarito para palestrar aqui com a gente, né? Para vocês aí nesse ciclo de seminários. Então, eu acho que isso é uma das grandes vantagens e, obviamente, a gente vai fazer essa limonada aí dos limões que vierem aí pela frente, né? Nos próximos meses e certamente, quase certamente, no próximo semestre também, né? Então, de novo, com isso, eu acho que a gente encerrou mais uma vez brilhantemente, né, com essa conferência do Dr. Heinz Laubling, né, como outras que a gente teve aí. Quer dizer, isso mostra a qualidade desse ciclo de seminários e, obviamente, o empenho aí dessa comissão em trazer esses pesquisadores, né. Então, eu queria agradecer a todos. E acho que deu muito certo, né? A gente pode depois consultar aí os alunos, mas eu tenho certeza que foi uma oportunidade muito boa e eu acho que a gente vai repeti-la com sucesso, com igual sucesso aí no próximo semestre, né? Então, queria agradecer a todos, e a comissão e aos alunos, e desejar um feliz fim de ano, né, dentro do que for possível fazer, e que estaremos de novo aí no próximo semestre. Tá bom? Um abraço a todos. Tchau, tchau. Obrigado.